Okay, you guys, welcome to Coffee and Cases. That's old, Brett.
Okay.
That's new. Cheers to
Cheers.
us.
I'm only on
Oh.
a plane, so they have no idea that.
This is my this is my new office, but the background lacks a certain je ne sais quoi, so I put up beautiful RUH in the springtime. So as we get started, thank you again for being here with us. I would like to start with a land acknowledgement. So we meet today on a virtual platform, but I'd like to acknowledge the Indigenous people of all the lands that we are on today and take a moment to acknowledge the importance of the lands which we each call home. As we gather here today, we pay our respects to the First Nations and Métis ancestors and reaffirm our relationship with one another. Okay, so it's going to be a really great session, but I want to just take a minute because someone asked after the last meeting, who is the TNK champion? And I forgot that that was something that we do. So hang tight. I prepared a little teeny slideshow, which I don't know. I'm sure. Oh yeah, there we go. Share. Okay, so let's take a peek at our monthly stroke metrics. And this is actually from the first quarter of the year. And and I know that not all of you are from the acute care or hyperacute part of the stroke system, but the metrics that I'm going to highlight today are kind of emergency room hyperacute metrics. But it's reflective of our primary stroke centers, so any center that has a CT scanner, we are all able to do neurovascular imaging and give TNK and start secondary stroke prevention. And so it's kind of reflective of that. So in Saskatchewan, between April and June, we had a total of 356 patients who came in as stroke alerts with a diagnosis of stroke. So this is the total volume of stroke. Stroke alerts are defined as someone who presents within the first 12 to 24 hours, like those two windows of having stroke symptoms. So anyone outside those 24 hours might still be diagnosed as a stroke, but those numbers just aren't captured here. So you can see kind of what our numbers were like, and just there were strokes in the Battleford, just a hiccup in the gathering of the data. But here's kind of a look at what our province looks like, and it's very typical of our 3-month blocks. So this is our IV thrombolysis volumes, and so it represents our TNK volumes. So, about 10 patients a month are getting TNK within our province. And this looks at our yearly kind of median door to needle times. And so again, North Battleford is not really represented, but they do give TNK there. Saskatoon, we do have kind of the best TNK times, but until, like, we're spoiled rotten because we have neurology right on site, and until we have a median of 30 minutes or less, we will not be crowned the TNK champions. So I just want to say, TNK champions for quarter 1. Nice work. An honorary TNK champion brain is sitting in my office with your name on. Okay. So that's the end of that slideshow. I'm going to stop sharing. I'm not sure if anyone was celebrating with us, but way to go, Moksha. Amazing. Okay, so we are going to talk a little bit stroke prevention clinic, and we have 3 stroke prevention clinics in Saskatchewan, and all 3 of our clinics will be represented, and some of the nurses are going to share about what they do in their clinics and kind of how things run. And then Dr. Graham actually is one of the stroke prevention docs.
Oh.
And I don't know if any of our other docs are on here as well, but I am going to start, or actually, why don't you start?
Sure, I can.
Introduce Ashley.
I will, but maybe I'll give maybe just a brief overview of the importance of stroke prevention clinics. We're so lucky that we have three in the province. There's been a study published in 2008. There's actually two studies at the time that's showing that having early intervention for people with TIA or minor stroke, and that's being like seen by a physician with stroke expertise or a nurse, assessed starting anticoagulant therapy, mainly aspirin at that time, and starting the stroke workup significantly decreased the chance of recurring stroke in that cohort by about 68%. So seeing people early, able to start medication and decrease the chance of recurrent stroke. But we know if somebody has a recurrent stroke after a TIA, they will have a 50% chance of being disabled from it. So having these stroke clinics, being able to see people quickly is very important. And also we're seeing these people in an outpatient setting. So we're diverting people from the hospital. And there's been a number of studies that show too that we save significant amounts of money in the millions of dollars by working these people on in the community like we do, decrease the chance of recurrent stroke and disability all in the city healthcare dollars, which is great. So there's some great history behind this, which is so very important. So I will introduce our first speaker, Ashley Trice. She's one of our nurses in our stroke prevention clinic in Saskatoon. She's been a neuroscience nurse since she graduated in 2014. I graduated high school in 1999. That's okay. That's okay.
Such a little thing.
Well, she initially started out working in acute care and neuroscience in career. That's where Ruth and I are today. But before starting the stroke prevention clinic, he did some work in public health with COVID and baby immunizations. His two young energetic boys, Hudson and Owen, enjoys exercising, gardening, and cooking, and watching the kids play hockey. It's just a bright light to have in the stroke prevention clinic. She's passionate about what she does. She always wants to make her patients' lives better. It's great to have her.
So Ashley, why don't you tell us a little bit about Saskatoon Stroke Prevention Clinic?
Okay, so our clinic is here in RUH. There's about 2 to 3 nurses working here a day. Meredith is our coordinator. Natalie works full-time, and then I'm here part-time. We have 2 medical office assistants here a day, and then usually 1 neurologist here a day. Sometimes we have 2 a day if we have a long wait list. Our clinics are Monday to Friday, usually 8 to 4. And we see anywhere from 7 to 13 patients. If we have a double doctor day, then we obviously are seeing way more than 13 patients a day. And then our catchment area is kind of anything north of Davidson, and then kind of depending on like the sides of the province, if it's closer to Yorkton or depends if they come here or Regina or Yorkton. Yeah. We also have the opportunity to do same-day CAT scans here because we're in RUH, which is kind of nice if we need imaging. And I think that's just the general overview.
Oh, thanks, Ashley. Carly, you are going to be up next. So Carly Hogan is the clinical coordinator at the Regina Stroke Prevention Clinic, and she's been in this role for almost 4 years. Prior to that, she worked on 5A neurosciences at RGH for 7 years and the surgical ICU for 5 years. So she comes with a really rich nursing history. Oh, yeah. And then in 2013, she did a brief travel nursing stint to Barry University Medical Center in Dallas, Texas, and Harborview Medical Center in Seattle, Washington. She lives in Regina with her husband, 2 daughters, and a senior English mono. Carly, tell us about Regina SPC.
So Regina Stroke Prevention Clinic, we're at the Regina General Hospital. We're on the same unit as the neurology unit. We're just an outpatient clinic at the front of the unit.
Carly,
yeah.
We can't hear you very well.
You can't hear me. Sorry, just 1 second.
That's getting better, actually.
If I'm closer, does that help?
Yeah, that's really good.
Is that better?
Yeah.
Okay. So yeah, we're Regina Stroke Prevention Clinic is at the Regina General Hospital. We're located on Unit 5A. So that is the inpatient neurology unit. And we're just a small clinic at the front of the unit. We have 2 part-time RNs, 2 full-time RNs, including myself. Can you guys hear me now?
No, it's still not Great.
Hmm.
You might need to switch your microphone. So how about while you're, oh, do you want to?
Sure.
That's better.
Oh, that's better.
Is it better now?
Yes.
Oh, I didn't do anything.
Oh, weird. Is it better for everybody else?
Yeah,
But
you
no,
guys can hear me now?
Yeah.
Okay. So we have 2 part-time RNs, 2 full-time RNs, including myself, who's the clinic coordinator. We have 1 unit clerk, and we have 9 neurologists that cycle through our clinic. There's a few neurologists that are stroke neurologists that are here more often. We usually see between 5 to 15 patients per day. We do half-day clinics and full-day clinics depending on the day and the neurologist. We usually do clinics Monday, Wednesday, Friday, but recently we have been trying to go to Monday to Friday clinics. We don't quite have the capacity for all the neurologists to do that, so we are just doing Tuesdays and Thursdays now as neurologists have time to do that. So we've been adding more clinics recently. Yeah, last year we had 1,317 new referrals, and we saw 1,220 new patients in stroke prevention clinic here. Yeah, so that's, oh, and yeah, Shelly, one of the IRNs, she's here with us today if Shelly wants to say hi, scoot around the corner.
Hi, Shelly.
That's all I'm doing.
Hey, thanks, Harley. Finally, but not
Last but not least.
last but not least is Kim Hoyt. So she is Kim. You want to turn your camera on?
He's keeping us in suspense.
Yeah, big time suspense. Kim just got a camera on her computer, so she is. I know you're going to do it, but while
Can
you're
you-
doing this, oh, I can hear you. I just can't see
Can
you.
you hear me? Oh, there I am. Hi.
Is the clinical coordinator at Yorkton SPC. In Yorkton, they have a once a week clinic, and it's run by telehealth with the neurologist based in Regina. Prior to her working in the stroke prevention clinic, she worked in the ER and ICU in Yorkton. And before that, she worked in the ER and ICU in Flin Flon, Manitoba. During her many years of nursing, she's seen the care evolve from nothing much we can do to time is brain. So it's exciting for her to see how much stroke care has improved over the years and all the hard work that's going into research and importantly, stroke prevention. Outside of work, you can find her reeling in a big fish or walking her lazy dog. So Kim, thanks for coming. How about you give us a little lowdown of the Yorkton SPC?
Yeah, for sure. So like you said, our clinic is a weekly telehealth clinic, and our neurologists are based out of Regina. There's 7 of them who rotate through our clinic, and we're staffed by 1 RN, me, and 1 office admin, Monday to Friday, 7:30 to 4. And we see probably an average of 10 people per clinic, and we serve a population of probably about 60,000. So I'm responsible for the triage and the booking and, obtaining the histories, getting any relevant test results, and arranging for fasting blood work if that's not been done prior to their appointments. So once they're booked, we put a chart together for the neurologist in Regina. We fax it there. And then the day of the clinic, we have a nurse practitioner here who assists with the neurologist with the exam and writes the orders. And then our office admin processes those orders. And once all the testing has been arranged, then the person is given like a care plan with the dates and the times of their tests and where they're going to happen, and then what follow-up will look like. So that's kind of how, and follow-up is determined by the neurologists. Some of them follow up here at the clinic, some follow up only for abnormal test results, and others just follow up through their office. So it really depends on the neurologist. And yeah, that's kind of how our clinic rolls.
Hey, thanks, Kim.
Yeah.
Dr. Brown is also on call this week, so he's just running out, but he'll be back. Okay, so I think it would be great to know, like, Ashley, maybe you can cover this. A little bit more about the referral process, like who can send them, what does the referral look like? I'm not sure if you want to tell us like how you're triaging kind of a high risk versus low risk, and then we'll get into some actual cases.
Okay, I am just gonna share my screen. 1 second here. Oh, share. Okay, so I'll share my screen. Let me know if you can see it. Ooh, I don't like this here. Okay, can you see my screen? All right, so on the SHA website, it's under acute stroke pathway. There's a whole bunch of information here. And this is where this referral and triage tool is what we typically get at the stroke clinic. We are an old-fashioned paper-only clinic, so we do get faxes for referrals. So this is typically what we would see when we get. Meredith, the coordinator here, usually does the triaging. Unless she's away, then me and Natalie will do it. So it kind of, you check off where the referral is coming from. We get referrals mostly from walk-in doctors, family physicians, different specialists like ophthalmology, neurosurgery. Sometimes we get ones from people that are already admitted in hospital for something and they've had stroke-like symptoms. So we'll follow up with them here, usually after they're discharged from hospital. It goes through, you know, when did the symptoms begin? This part right here is really important because that kind of dictates how urgent we see people, as well as the symptoms down here. We want to know how long the symptoms lasted for, and then here they'll usually write a brief description in, kind of go over any health history, any medications they're on, and what testing they've had. So I made up a mock one that we'll talk about now. So this is John Smith. He came in 2 days ago to the emergency department. Dr. Jane Doe saw him. Symptoms started at 12 o'clock. So this was within the past 48 hours. He presented to emergency with left-sided weakness and numbness. He has a history of high cholesterol, diabetes, and hypertension, and was started on dual antiplatelet, meaning aspirin and clopidogrel. And then he did end up having imaging of his brain, which was great. So using this, if we go to, if we go here, there's kind of like this little triaging tool that we use to kind of see how urgently we need to get these people in. So he presented with left-sided weakness and numbness. So right here, if we look at these, you know, maybe it was transient, it doesn't really say in the referral, it's a little bit vague, but he did present with the leg weakness within 48 hours. So that makes him high risk. So usually that means hopefully they've contacted an on-call neurologist, they've had imaging done, and then they're started on aspirin and Plavix and sent here. Sometimes the triaging can vary very differently. For example, if they're seeing, if it's a symptoms less or way more than 2 weeks ago, it automatically puts them in a lower risk. I gotta move my picture here. And then also with numbness, so this, let's say this guy came in with numbness, and once we kind of, the referral didn't say left-sided numbness, maybe it said like numbness on left leg and right arm. It would be, or, you know, it's kind of patchy or it's different, presents at any time, it's low risk. So that's typically how we triage the patients. And the high risk we try to get in within 48 hours if we can. And then once we go to book them, We typically will kind of go based on like if they're in Saskatoon, if they're still having symptoms, we'll bring them in so that the neurologist can assess them. Let's say they're way up north and it's going to be like an 8-hour drive and they kind of don't really feel like traveling. We'll do a telehealth appointment so that the doctor can still see them and assess them via video, which is great. What else? So high risk, low risk, the triaging pathway. We actually do, some days we'll do like 2 to 3 same day CAT scans, which is kind of nice. We get squeezed in. I think that's about it.
Okay, I wonder, Brett, do you want to comment on kind of the high risk, low risk, what, why, how, when?
Yeah, actually, we actually just showed the provincial triage tool, and that's based on some research there. Like I said before, if you have a TIA or minor stroke and high risk for having another stroke, 50% of that risk is front loaded within the first 40 hours or so. But then seeing someone and starting antiplatelet therapy is important. And likely with these tools, a lot of people are presenting to emergency departments where they get seen and scanned for their neurovascular imaging, and they get started on, in most cases, dual antiplatelet therapy with aspirin and clopidogrel. So we've kind of moved some of that early, instead of having a 24/7 stroke clinic like they had in those studies back in 2001 I was talking about. We push that to the emergency room. People go, they get seen, they get scanned, and they get dual antiplatelet therapy. The reason why we ask for neurovascular imaging, the reason why we get same-day CT scans, like Ashley says, for the people who don't have it, is to catch people with tight carotid stenosis, because that's the group of people who are the highest risk of recurrent stroke, and they would have to get a slightly different intervention to get best medical therapy. That's usually a carotid intervention with a carotid endarterectomy or a stent. And ideally, doing that as early as we can within the first 14 days substantially decreases the risk of stroke. A lot of MRI studies have shown that the speech and motor symptoms, so facial group, arm weakness, aphasia, or dysarthria, are higher risk than something like unilateral numbness by itself. Just having numbness doesn't rule out stroke, but it's a much lower risk. So that's why we're trying to capture the people who've had their events in the last couple of days. They're higher risk than, say, a month ago. The people who have speech and motor TIAs as opposed to people who have sensory. I'm not saying that's not a stroke, but it's lower risk of the people who are a high risk carotid stenosis. So that triage tool, we're trying to find those people who has the highest risk symptoms based on time, based on the symptoms. Do they have neurovascular imaging? That's how we try to triage them, like we actually say, so we can catch the highest risk people first.
So say I'm having these symptoms and they resolve. Sometimes I might go to my family doc, but sometimes I might actually go to the emergency department. Are these types of TIAs an emergency that you should run them like a stroke alert, or what would you suggest there?
Yeah, if somebody has symptoms that they resolve, they don't need to run as a stroke alert. But if you look at our triage tool, which is based on maybe best practice guidelines, ideally we want to get people images as soon as possible. So that'd be maybe sometimes that day. I was on the phone today, got a call about a TIA down in Indian Head. The closest scanner is Regina. I'm like, yeah, that sounds like a TIA. Let's try to get them scanned today. They don't need to go there in an ambulance. They get them scanned. Look at the brain, but more important, look at the arteries, and then we can start secondary stroke prevention, which is like really antiplatelet therapy. We don't have to be stroke alerts, but we try to get them scanned as soon as possible. So if somebody comes in, say at 4 o'clock in the morning, when ED and the radiologist is not there, and they have a TIA, their symptom resolved, it's okay to wait 4 hours till 8 in the morning to get that scan. You don't need to call it. We have a little bit of time, a little bit of wiggle room.
Great. And again, you guys, although Ashley is actively presenting, she's also helping with the chat, and we're watching the chat too. So if you have any questions or comments along the way, please feel free to throw them in.
Yes. Test my multitasking skills.
Okay. Jim, do you want to share a case study about kind of a typical patient you might see coming into your stroke prevention clinic, and what kind of what the flow of that patient might look like?
Sure. So I did a case study on a fellow that came through the stroke clinic. He was actually 92 years old, but very spry and active, still living on the farm. Him and his wife were still both out there, very independent. And he woke up one morning with a weak and kind of clumsy left arm and hand. Said he felt like his hand was sleeping, he couldn't button his shirt, and he was just feeling a little bit off balance. No facial droop, no change in his speech. So his family drove him to his local ER, and he was assessed as having some weakness in his left hand. The rest of his neuro exam was documented as normal. So he was not treated as a stroke alert, but the physician in his local ER did consult neurology, and the neurologist recommended starting a dual antiplatelet. So he was started on aspirin and Plavix, and also started on Lipitor 20 milligrams daily, and then was referred to the stroke clinic. So we saw him 3 days later, and the neurologist on the exam noted him to have about a 1 out of 5 weakness in the left arm and hand, a bit of weakness in his left knee flexion, no pronator drift, and he did have a mild decreased left nasolabial fold with his smile. And he had good sensation, speech was normal, eye movements were normal, and so he was diagnosed with a minor right hemispheric stroke. So the testing ordered included a CT, CTA, which we were able to do the same day. We have, I think, 4 spots available in our clinic days, so we can squeeze people in for their imaging. So his CT showed a bit of atherosclerosis and moderate stenosis of his right internal carotid and his right vertebral arteries. Then a carotid ultrasound was requested, which showed 50 to 69% stenosis of his right carotid, extending into the proximal internal carotid. And he had a fasting lipid profile done prior to his appointment, and his cholesterol was high. Total cholesterol, do you want me to go through the numbers or just say that it's high?
Just high, I think is good.
Oh, okay. And so then we also did an echo, and that was reported as normal for his age. And a Holter was also requested, which revealed a new onset AFib. So that was likely the cause of his stroke, cardioembolic. So his aspirin and Plavix were stopped, and he was started on apixaban 5 milligrams twice a day. Instructed not to drive for 1 month post-stroke, and a referral was sent for outpatient physio regarding that weakness of his left hand and unsteady gait. And then follow-up was just arranged with his family practitioner in 3 months for repeat lipids to target an LDL of 1.8. And then we talked about lifestyle modifications to manage his risk factors, like med compliance, Mediterranean diet, regular exercise. Again, he was no driving for 1 month to monitor his blood pressure regularly. And he was advised to contact our office or his neurologist's office if, he had any questions or concerns. And he was given a stroke journey booklet for education and reference. So that was our little 92-year-old man.
Adorable. I'm sure he was a cutie.
He was very cute.
It's a TIA clinic, but he came in and still had some residual symptoms, and he had an actual stroke.
Yes.
So,
Yeah, this is especially since the poll there is about almost a third of people didn't know what a stroke prevention clinic did, and that's didn't even know it existed. So this is very important too. When somebody comes in with a TIA or minor stroke symptoms, and they're get diagnosed with that, we got to try to figure out why it happened. There's a lot of different mechanisms that can cause stroke. And that's a big part of stroke neurology is to figure out where that clot came from. So that's why they ordered the echo, the filter, they look at the arteries. Because depending where that stroke came from, if we change our management, help decrease the chance of recurrent stroke. In that case, they found atrial fibrillation, you know, an oral anticoagulation, say historically warfarin, but now we have newer medications. They're about 3 times better than aspirin at preventing recurrent stroke, so that's great. If they have a tight carotid stenosis, they can get a carotid endarch, a stent. They can decrease the chance of recurrent stroke substantially over the next 5 years, right? And at the same time, too, looking at all the vascular risk factors, high blood pressure, cholesterol, sugars, physical activity, smoking, all those things. Because if we address all those things, we can substantially decrease the chance of recurrent stroke early on. Like I said, if you have a recurrent stroke after TIA, you're very high risk of disability and we want to prevent that. So that's why people get seen quickly, and that's why we get the workup to fine tune treatment to prevent recurrent stroke.
And then one of the questions that popped up was in regards to what happens if you're having a TIA, call 911, or have stroke symptoms, call 911, they resolve on route. How should the emergency room deal with that? And, you know, like EMS, I cannot say enough how important they are in the whole stroke process. And again, that they are exactly who you want in the field, and when they roll in, they have so much good information to give us and really kind of help us. You know, they're already in their report. We're localizing where the stroke was in their past medical history. We're finding out, gee, what might the etiology be? And bless their hearts, they come in and here's this patient, and they're like, "No, I promise you, they were aphasic, and now they're talking away." And so they sure feel sheepish, but they're excellent assessors. And so what do we do with this?
Yeah, and we've had this before, right?
Yeah.
So if somebody comes in and they've had symptoms that they're resolved, even though they come in with a stroke alert, and you kind of examine them. If it's resolved, you have a moment to pause, right? So again, if it's 6 o'clock in the morning, the radiologist is not coming until 8, you know, waiting for that scan for 2 hours to get it is okay. Sometimes we've been in a couple of situations too. There's a trauma one day and our stroke alert that came in the other day, and they go through the CT scan. They say, "Hey, this person's resolved. We don't need to get this image right at this moment. The trauma can take over the CT scan to get that, and then when that's done, we can go over and get her scan." So if the symptoms have resolved, it allows us to pause a little bit, right? Delay the scan by a little bit if need be. But if it's in the middle of the day, and no one's using the scanner, you can see them. We still need that vascular imaging. So if they're there, we can get the scan right away. But we have a moment's reflection and
And one of the, actually, I just had an email from one of the rural educators. This is a bit off topic, but kind of asking about on the rural stroke screening, when the TIA or stroke comes in the rural facilities, we have that they allow for permissive hypertension of 200 over 100. We don't treat if it gets that high. And one of the questions was, you know, that seems like quite a high blood pressure, and we're usually a little bit uncomfortable with that in the periphery or in the ambulance, or even like when you get into the emergency department, because everything in our brain screams like lower the blood pressure. But you know, in patients like these, even in like a TIA, they might have a residual high blood pressure, and that's exactly what we want our patients to have. We want them to have permissive hypertension, because as Brett said, like if they have these tight pipes, we're trying to use the blood up through the pipes, or if their brain's not perfusing, their body naturally turns up the pressure to try and get blood up into the brain. And so it's important to just remind ourselves, take a pause. This blood pressure is exactly what we want in the short term. And as well to tell the family who is watching that monitor thinking, holy smokes, their brain's going to explode, that the body is doing what it needs to do, and just take, you know, it's okay. When we get excited about the blood pressure, you can get excited about blood pressure. And about 25% of our patients have stroke caused by those tight pipes in the neck. So we're happy with the high blood pressure. Okay, I don't know if there's any other questions, Ashley, or maybe we'll see you at all.
Just that one.
Okay. Carly, do you want to share a typical case that you might see in Regina?
Can you guys hear me better now?
Just keep talking.
Pardon?
Keep talking.
Okay. So our case study is we have a referral from an ophthalmologist for a 75-year-old female, and she describes that she's had 2 episodes of painless vision loss to her right eye, lasting about 10 to 20 seconds. And she describes it as a curtain, like a gray curtain coming across her eye. So she did not go to emergency. She went to go see her ophthalmologist. When the ophthalmologist examined her, her eye exam was normal. So he sent a referral to us here in the stroke prevention clinic. And he started her on aspirin. He also let us know that she has a history of coronary artery disease, hypertension, sleep apnea, type 2 diabetes, dyslipidemia, and is an quite heavy smoker. So when we're triaging her, this is a case I find super interesting because working on the unit when I worked on neurology, I never saw this, but this is called amaurosis fugax. So it's a combined Greek word, which means darkness, which is amaurosis, and the Latin word fugax, which is brief. So it's a brief loss of sight in one eye. And usually people don't go to emergency for this. They'll go to an ophthalmologist because they think it's an eye problem, which is understandable. So we will triage this as VHR, like a very high risk patient, because the last episode was within the last 24 to 48 hours, and they don't have a CT scan because they're being referred from ophthalmology. So we will see this patient as soon as possible. In their appointment with the neurologist, he does do a diagnosis of amaurosis fugax. So diagnostics that were ordered are a CT brain, CTA of the cow and carotids. And in Regina, we also do have same-day spots available for CT. So right from our appointment with this lady, she'll go for a CT scan right away. We've also ordered lipid panel and HbA1c to check her cholesterol and blood sugars. We've ordered a Holter monitor to roll out any cardiac arrhythmias and an echocardiogram. In Regina, we also do have same-day Holter monitor spots and same-day ultrasound spots. So she'll go for her CT that day and her Holter monitor that day. So if we send someone for a CT one day, we check the results right away the next day because they will be available. And the CT shows that she has high-grade stenosis of the right internal carotid artery, greater than 70%. So this is also interesting because her amaurosis fugax is on the right eye. Her carotid stenosis on the right side. Is that symptomatic? Does anyone know if that is considered symptomatic? Ashley. So in this case, if it's the eye and the carotid, that is symptomatic in this case. So because she has symptomatic stenosis of the carotid artery, we will send for an urgent vascular consult for her. So it's a pooled referral in Regina for vascular consult. So again, the day after she gets the CT done, we look at the results, we tell the neurologist, we tell her we're sending a referral to vascular surgery, and then vascular surgery surgeon sees her within 5 days. And then she ended up having a carotid endarterectomy within 10 days of seeing us. So I think that's one of the really good cases that works for stroke prevention clinic. We found the major source of this, the stenosis of the clot that was causing the symptoms, and had surgery within 10 days. She also did have high LDL, so we started her on a high dose of a statin. Her HbA1c was normal, and her Holter and echo results were normal. So she already quit smoking, which is great because that was probably being a heavy smoker in the past. That's one of the major causes. She may have had the stenosis as well as the high cholesterol. She'll continue aspirin lifelong. She'll modify her risk factors, again, lower her cholesterol, Mediterranean diet, sleep, stress management, follow up with her family doctor on a regular basis to help manage her blood pressure, cholesterol, and all those modifiable risk factors that she can work on. And then when we followed up with her, we touched base with her in a few months, and she was doing well and no new episodes of any vision loss.
Okay, vision is such an interesting kind of stroke syndrome because you
Hey,
can
Ruth,
have, yeah,
you're just a little bit muffled.
I don't know. If I talk louder, is it better?
Yes, that's better.
Okay. So vision is such an interesting stroke syndrome because, as Carly said, you can have just kind of one eye affected, or you can have two eyes affected, depending on what is going on. And I know, like Sanchea or Dr. Wazel, who's one of our stroke neurologists that works in the prevention clinic. And Sanchea, do you want to comment just a little bit on eyes and carotid versus occipital lobe and the differences and the fact that eyes can be treated with TNK.
Yeah, lots going on there. And so great case. Thank you, Carly. And just kind of really showing how high risk these patients can be and how like we really want to see these patients in clinic. It's great when they're coming from ophthalmology because then we know they've had a really good eye assessment to rule out a primary ocular disease that could give monocular vision loss like that. And then otherwise they get quite concerned for the same side, the carotid being stenosed, especially if you're getting that repetitive painless history. So ideally, if they're coming from ophthalmology, they would have a CTA done to rule out carotid stenosis, but I think we see that more often when they're coming through our urgent eye clinic at City Hospital and they have access to a CT scan right there. I think when we're hearing monocular, we think about more primarily coming from the carotid at that point. If someone's telling the story that maybe half their vision was missed and they just appreciated it more at the right eye, there's still certainly the chance that they've actually had vision loss out of both eyes, but they're just not appreciating the involvement on the opposite side with both eyes open and being compensated. Because if we have more of the homogeneous hemiopia, meaning the visual field out of both eyes to one side. So let's take kind of the right vision, right-sided vision of the right eye, but then it's more the nasal vision of the left eye is both lost. Then we think about where those pathways come together, and often we're thinking more the occipital lobes with that. And that's different than our carotid, which is our anterior circulation that moves now to our posterior circulation with our vertebral arteries and our basilar artery. So if you actually got the scan done and we saw stroke of the PCA or occipital lobes, but yet we have this carotid stenosis, that you could have like an incidental or non-symptomatic carotid stenosis, and it's actually the posterior circulation that's giving you troubles with that. So eyes are tricky, and so that's why it's so key to have kind of our ophthalmology assessment and then us getting the information even further. I think like the vascular team are quite happy to jump in Saskatoon if we identify like a carotid stenosis with our same day CT. Sometimes we're calling like our neurovascular team to come see the patient right during their appointment to keep the ball rolling. They've been excellent to do that.
Thank you, Sanchea. Okay, we are like 3:43 and we've got two other big topics to cover. So Ashley, here
I can talk pretty
in
fast.
Okay, and so here in Saskatoon, we do stroke prevention. We do follow-up, so inpatient follow-up in the stroke prevention clinic, both by phone call by the nurses, and then a 3-month-ish visit by the neurologist. So do you have a case study that kind of would represent one of those patients you would typically see?
Yeah, I do. So the triaging form that I made actually is based off of a real patient. So John Smith there that presented with the left-sided weakness and numbness. He was seen at the stroke prevention clinic, and I actually ended up doing his phone call. So we do what we called cold calls. So they're not booked appointments. We usually look 6 weeks behind, or sorry, I look 6 weeks prior to the date and kind of call patients that we've seen 6 weeks ago. So basically I call them, ask them if they have a couple minutes to chat. I just want to go over their blood pressure, if they're taking it at home, if they're still taking their medications. Sometimes people get, it's a lot at the stroke prevention clinic sometimes if you start taking medications and, some of them you're only supposed to take for 21 days and people, and then a statin or a cholesterol medication gets added onto it. People can get their medications confused easily. So I may just make sure, if they were supposed to stop one of them, that they've stopped the one medication and they're continuing on the other ones. Talk about side effects, talk about the event that they had, if they've had another event similar, or if they're noticing any new symptoms. And that piece is really important because we also do a mental health screen at the same time. And there have been patients that I've seen that have been quite depressed. One patient I ended up booking for counseling the next day, and I talked to him. He ended up actually going to Jubei Center a couple days after I talked to him. So that was really good that I touched base with him and was able to encourage him, to seek help. But the one that we saw with the left-sided weakness, when I was talking to him, it turned out that he was actually tripping a lot at home with that weakness. It was kind of intermittent and he was just falling more often. This was actually one of Dr. Graham's patients. So I did my assessment. So I did my assessment over the phone. And I asked him, like, oh, are you interested in going to physio, or do you think occupational therapy could help with that arm while you're trying to do things? And we actually did refer, with Dr. Graham's permission, I did end up sending him to the Ross program, which is inpatient rehab at City Hospital. So that was really great. And through these cold calls, we do actually, it's a really good time to assess, how are you managing at home? Oh, do you think home care? We can refer you to home care. Oh, you're choking on fluids. Maybe, have you ever saw a speech pathologist? Maybe we should refer you to speech therapy and they can see you. Or mental health services. So that's where I have our book here. So this is our community referrals binder. We call it Lucille because it's the big gun. So it's province wide, but we would love to get an updated online, just something we can send out to everyone so that we know, where's physio, where's the closest OT, who has SLP, especially outpatient programs like walking programs. It'd be so great to know to refer patients to these things, especially during these cold calls. And then I also make sure, they're getting their tests done or they have appointments booked. And then we kind of go over risk factor awareness again. And if we need to talk about diabetes or, education or nutrition, maybe refer to a diabetic educator at the time. That's really, I really enjoy doing the cold calls and getting people the help that they need. Yeah. So he ended up going to Ross, and then I think we saw him in follow-up a couple months later and he was doing much better. So that is our cold call. And then Ruth, would you like me to talk about some resources and stuff that we typically use here?
Brett might want to comment on follow-up from the dog perspective.
Yeah. What kind of Ashley and the team does.
You have to stand a little bit closer, I think, to the mic.
Sure. What Ashley and the team does is great in regards to our patients discharged from the stroke unit or our patients diagnosed with TIA kind of go home. Because people can struggle in community and a lot of times they don't reach out, right? So having these cold calls to see how they're doing is great because we can have you have further stroke-like symptoms. Are you taking your medication the right way? Any complications because of it? And also asking, are they struggling? Do they need to see community therapies? Do they need to see, because post-stroke mood disorders are real, do they need to be plugged into community resources for mood? There are online resources for that. Do they need more kind of inpatient like Ross? It's a really good way to kind of touch base with people and also screen for all those issues. I don't know if Ashley mentioned it there, but also screen for mood. They give you like a Barthel index to see where they're functioning okay at home. It's a good way to see all the visual and invisible post-stroke symptoms but check on those. Because really, in the end, we want to really augment people's quality of life as best as we can, and then try to partner with their primary care provider and partner with community resources, get them plugged in to ultimately improve their quality of life. So it's an excellent work that they do, and I think it's paying off in dividends.
Okay, so we have 10 minutes left. So Ashley, yeah, if you want to share some of the community resources and maybe that Heart and Stroke website that gives everybody kind of provincial options to look at in terms of different needs your patients might have for support. And then just what Ashley said, we're trying to build a bit of a repository that we can share and use and disseminate around the province so that there's options for post-stroke care in the community.
Yes. So I put two in the chat. One is for the services that Ruth was talking about through Heart and Stroke that talk about what they have for each province. And then the other one I put in there is rehabscience.usask.ca. I really like this one. We actually have the poster up in our rooms. So it's called NeuroSask, and it's available for patients that have a neurological condition. It's all virtual, which is really nice, and it's twice a week. They usually do like an active session on Tuesdays and Thursdays. And then afterwards, they have about a half hour of doing stretching, and sometimes they have guest speakers, or they have like a little coffee and chat, kind of like we're doing right now. There is quite a few like stroke recovery. Oh, there we go. Thanks, Ruth. There's some stroke recovery associations throughout the province. March of Dimes has some online peer support groups. I will also put this in a document and send out tomorrow with the survey for our session. And then one other thing that I made some pamphlets actually. So let me just, oh, you stopped sharing that. I will show you. So we have this printed up at the Stroke Prevention Clinic. So if you scan this QR code, it will take you to the website that we have a whole bunch of the different diagnoses that we see here. So there's one on stroke, carotid stenosis, syncope, amaurosis fugax. Trying to think of some other ones off the top of my head. We have one on atrial fibrillation, PFO, medications for stroke. And I have been working on a couple extra ones as well.
Yeah, and I think you search on the SHA website for the PIER, PIER documents, the patient information and education resources. You can find some of the stroke specific ones that Ashley is referring to. So if you don't have access to that QR code, they're all up on the Infonet under it's also kind of tricky to find, but it's under the PIER document.
I will send it tomorrow.
Thanks, Ashley. And again, like if you guys have any resources that you're like, ooh, I wonder if everybody knows about this, please share them, like reply to Ashley, and we'll keep making a repository, because one of the other nurses, Natalie, is working really hard to get kind of a comprehensive document made. So we have about 7 minutes. If there is any questions, either for any of the nurses, so Harley and Regina, or Kim and Yorkton, or Ashley, and then like Dr. Graham and Dr. Wazaloo are happy to jump in as well. I don't know if Sentia is still on, but oh yes, she is. She is.
And also, I did put out a question there because viewers' choice is next month. There's only 4 votes, and Ruth is 2 of them. So if you could comment what topics you'd like to chat about, then we can get something lined up.
Hey, are there any last minute thoughts on stroke prevention? Stroke prevention clinic?
Sarah Marshall raised her hand.
But lowered it.
Hi. Oh no, that was an accident.
Oh,
Hi. I was just wondering, of the patients you see, how many do you feel get referred on to rehab services, either Ross or Wascana or local services? Just from experience here at Wascana, we try to prioritize our referrals from the stroke prevention clinic because we find that people are good enough at home to be at home, but have a lot of questions, and they often come in. They don't often need much, but they often need some reassurance and a little bit redirection. So we do try to see them as a priority through our program, but just wondering how many of that collection do we feel are getting passed along?
We might have stats. Ashley, do we have stats?
don't have any stats for that. I don't know if Meredith has a tracking for that or not, but I don't have any, unfortunately.
I think she does. I think Meredith's the coordinator. She may be online, but we can certainly.
I can figure it out and put it in an email tomorrow, the recap.
But it does happen. The same thing, the Ross program, just like it sounds like Wascana kind of fast tracks things from the stroke unit or the stroke prevention clinic. So they try to see those people fast, right? So they could be home, but they need maybe therapies a few times a week when they do that through the Ross assessment. Props to hear that Wascana is doing the same thing. It's a great way to get people keep them in the community, but get them access to therapies quickly. And there's a question here about is high cholesterol treated at every age? And it depends. It depends on the mechanism of stroke. So a lot of young people have strokes due to arterial or carotid dissection, so tears in the artery. Those ones don't really need cholesterol lowering. That's not the ideology. But we're seeing more and more young stroke due to traditional vascular risk factors: high blood pressure, smoking, diabetes, overweight. If somebody has a stroke like that falls in one of the traditional categories, then yes, we would probably start a cholesterol pill to lower that. And there have been studies that shown that young people who have stroke, who get started on a cholesterol pill, they have fewer heart attacks and strokes moving forward. And also young people become old people too, right? So there can be some benefit. But not every young person with a stroke gets a cholesterol pill. It's kind of based on the underlying mechanism.
Okay, there's a couple other questions. The initial stats did not have a record for North Battleford, and I missed why. I just think there was a blip in the data, but Aiden from North Battleford does an excellent job. And so stay tuned. There will certainly be North Battleford stats. Lloyd, as everyone in the province should probably or is aware of, is a border city. And so we get some of their Saskatchewan patients, but they have a lot of Alberta patients. So if it's an Alberta patient, they report those metrics to Alberta. If it's a Saskatchewan patient, they report to Saskatchewan. As well, I'm not sure where you're from, Fran, but they have had a turnover in their stroke prevention clinic, like the person who collects the data. So still something we're following up on. Samara, we will give you an email update about Ross and inpatient as well as outpatient speech and language pathology from in Saskatoon. And Ashley just wrote in, so Ross stands for Rehabilitation Outpatient Specialized Services. And that is usually kind of a Saskatoon and area program. But they do, unless someone's on here and wants to correct me, sometimes patients can see them in person and then do some online therapy with them. So like we're trying to build more capacity around the province for rehab. And I think like that one document that Ashley pulled up about the online program is really, really a cool opportunity for us to refer our patients to. Okay, you guys, it is 3:59. It is the Thursday before the long weekend. So, um, next month we have a rehab focus. We have shoulders, and we have culturally appropriate care for the rehabilitation patient, and maybe a little something something. And I want to give a shout out to some of the RTs that are on. Ashley and I have gotten your emails and we're going to be contacting you. You guys are excited to present and we want to hear from you. And if anyone else on here is like, geez, I'd really love to present at Coffee and Pieces. We have quite a long application process, but we will consider you. I'm just kidding, there's no application. Thank you guys for it.
Happy Thanksgiving.
Cheers to you. See you next month.
Bye.
Bye. Happy Thanksgiving.
Thanks, Kim. Thanks, Carly.